Ladies and gentlemen, a very warm welcome. Of course, we are expecting one more important person in the room, but we will already start thanking you to spend your lunchtime on nutrition, which is a reasonable choice, but as you will see, not the case for a lot of our patients, so thank you for being here. Also, a warm thank you to Nestlé to facilitate this meeting, to have this knowledge transfer from all over the world, and also to give the opportunity to have an intelligent approach to enteral nutrition. So thank you for the opportunity. And of course, the speakers of today, from a practical viewpoint, Professor Pierre Singer will be joining us online. There will be a spoken PowerPoint, and then he will join us for the Q&A because the global situation does not enable him to travel. So the impact on research is also there, which is a bad thing. So please welcome to Metabolic Stress and the Central Role of the Gut in Critical Illness. My name is Elisabeth Waele. I'm a surgeon by background, intensivist and clinical nutrition expert, and I am very happy to give you some insights today on insights on the crucial role of the gut in nutrition in critically ill patients, and those are my disclosures. So first of all, ladies and gentlemen, the fact that you are here, and yes, there are a lot of people here in the room, shows that you have the capability, you have the ability to change and to transform nutritional therapy. Now, is this necessary? Why are you here? Because you have three interesting ways to reflect about nutrition in critically ill. First of all, you can become a smarter doctor or dietitian or nurse. You can approach your patients in a more intelligent way and not lose too much time observing one single patient day 1, day 2, and day 5. So let me show you how you can be smarter by patient profiling. Of course, if you want to increase the quality of care, what you are willing to do because you are attending a medical congress, how to do that? Practical implementation is a challenge, but it can be done. And of course, we live in rough times, so how to be intelligent with money is also something interesting. And sometimes it's not, what you see, but you have to think and know some data. So I will talk also about what enteral formulas you could intelligently use for your patients. So first of all, some personal experience. We studied our own center here in Brussels, Belgium, and we published the fact that even in a nutrition-focused ICU, getting to 100% of feeding adequacy, that means intake compared to what the patient needs, is not always easy. Our data included COVID patients, so we went a little bit down on energy and protein. Normally, our ICU is above 20% above the global average in feeding adequacy. And some of you might also see that once the patient leaves the ICU to the ward, energy and protein adequacy decreases enormously. So my first question to you, do you know how well your patients are fed in your ICU? It's not only in Brussels. We have here data from China, very recently published, where you can see that in 6 out of 10 patients, there is an opportunity for improvement. And we have this myth of overfeeding patients. And maybe a long time this was a reality. But now you can see that only 1 out of 4 are actually overfed. 1 out of 3 are underfed. And 4 out of 10 are well-fed. So if there's something that you can change in your ICU and in your clinical practice, the huge possibility of nutritional therapy is just staring at you. There is room for improvement. Now, why is that? Because we are trained on, welcome, Professor, because you are trained to recognize and to be very smart with, let's say, the usual stuff in ICU. What about lung injury? You have read it, you know it, you act on it every day, and you use intelligent strategies. You're not going to blow up the lungs. You have evolved. You will be smart. You will also look at the feedback from the patient, and you will change and fine-tune your treatment. Well, ladies and gentlemen, today we're talking about this 5th organ, the gut. The gut can also be compromised. The gut can also need a gentle approach. So a gentle approach, as you do with the lungs and the kidneys and the hemodynamics, have a gentle approach on the gut. This means that you will have to think about low-dose feeding, about what about energy and protein, appropriate formula, the workload that you put on the GI tract when it has to digest nutrition, while the patient is fighting for her or his life. So be smart, and you can be. Now, how can you be smart with nutrition? Well, of course, AI, and Professor Singer will tell us all about this, can help us to make better decisions at an earlier stage. And one of his publications showed that when you look at some data, clinical data, genetic data, biochemical, and gut microbiome, for example, you see clusters of patients. You see clusters of patients, and some will benefit of enteral, some will benefit of parenteral, but some at that time point will not benefit from medical nutrition. So this is smart. This is telling you now is a good time to go for it. Is the nutrition a pleasure or a burden? And we don't have good bedside monitoring. We don't have a CRP to tell us, now you need to go down with your antibiotics or you can stop them. We don't have this single biomarker, so we need to be even smarter than, antibiotic dosing, exaggerating a little bit. So AI can help, and when you put your single patient that you're responsible for in this model, the model will tell you, go for it, don't go for it, go slowly. So this is a smart approach. And why is that? Because critical illness has consequences. When you as a bedside physician know that your patient has been exposed to a lot of antibiotics, you can expect, maybe there have been some fluid overload, you may expect that there can be gut dysfunction. There can be gut dysfunction, and it can have an impact, of course, on several aspects, like the absorption of enteral nutrition. We don't know yet what happens when you pour the enteral nutrition in the patient, and the patient has diarrhea 7 times a day. What is the cost effectiveness of your enteral nutrition? You don't know. But you know that you have to be gentle. But on the other hand, don't do nothing. You can act, because as we have seen, only 4 out of 10 are adequately fed. So you can do something so that you can do some damage control on the muscle wasting, and not only walking, but also the heart and other muscles, the diaphragm, are really important for a critically ill patient. The cognitive impairment will also have an impact on nutrition, even more after ICU. What is your patient is in a delirium? They testimony about those really bad experience they had from a cognitive point of view when they were critically ill. This has an impact on nutrition. And then we know the metabolic imprinting of high-level inflammation. The mitochondria become less and less efficient in dealing with the nutrition. So yes, there is an impact, and we should incorporate all of that in our smart movement. Now, on a short term, what can you do next week if you say, okay, I want to be smarter with nutrition? Use what is available. All the parameters that you see in this slide are available to you. It's not hocus pocus, it's not very fancy, it's about age and Apache 2 scores. If you see less than 5 points, low risk for feeding intolerance, just go. In our ICU, in the brain injury patients, we just go for target on day 3. We don't ramp up from 20 to 30 ml and just measure gastric residual volume. The nurses know it, that in those patients, it's not necessary. We can just go to target. That is also, profiling subgroups. And of course, you need to be careful, and you will monitor the patient's behavior. But in some patients, just go for it because the patient needs it at this time point. On the other hand, like I've seen, we want to avoid overfeeding, because overfeeding has negative consequences. Mitochondrial overload, the autophagy story that we have talked so much about it in the last 10 years. So yes, of course, but the danger of overfeeding can never be an excuse not to feed a patient. And we are fighting a monster that is only very small, because underfeeding was 33% in the Chinese ICUs. So more patients are suffering from undernutrition than from overnutrition. And of course, you don't want to contribute to this multi-organ dysfunction. So yes, you want to be smart, and yes, you want to be careful. And this is why you can optimize your nutritional therapy. Now, how to do that? As we said, we don't have good biomarkers, but we are advancing in medicine. This is a very recent trial published very recently. And here, for example, the authors say that you can have insulin resistance index as a kind of clinical marker to feeding responsiveness. Is the patient ready or is the patient not ready? Very promising. But of course, we have to see if you use this in a prospective interventional way, if we will have benefits. But the future will tell. And when I saw this for the first time, I imagined, the feeding guidelines that we have, you just mirror them because we are very careful on day one. Because we know the patient will probably be very catabolic and the nutrition, the exogenous nutrition, will be a burden and not a pleasure to the patient. But on day 2, day 3, the amount of patients that have already made the transition to anabolism, they will benefit and we don't want to starve them. The same is true with endogenous production. We know the liver will make glucose to take care of itself, but after a day or two, it will be gone, and we will step in and help the patient. So first message here, be smart. Get your nutritional therapy to a higher level. Now, if you feel motivated, if you think my numbers can increase too, I become better at what we're doing right now. How to do that? There is no single solution. This is an illustration that I show you, not because I'm in favor of cyclic daytime feeding over 12 hours. There is no evidence that shows you that it is better than continuous. Why I show it is that because while doing that, while implementing a protocol that they defended, you could see the total volume of the enteral nutrition went from 60% to 90% in a shorter time point, just by giving it attention, having a plan, having the implementation of the plan, and measuring what you're doing. The whole world can take an example, have a plan on advantage, and do it for the good. So this is what's happening here. If you have a strategy for improvement of care, you can do it. And this is even a better example, where also 2026 publication, nutritional support team guided nutritional compliance, improved the outcomes. A protocol. Please base it on, for example, European Society of Clinical Nutrition, on ESPEN guidelines, or your National Society for Nutrition. If you have a protocol, you implement it, you can see that compliance can go up. And there's also hard outcome data. Shorter in-hospital stay, lower mortality. There is proof on the table. Food is not just for fun. It has hard outcome impact. And this is important, because who is going to do this? Is it going to be you as a dedicated physician or dietitian or nurse? Or do you want to lobby to the management that you want a dietitian in your ICU? I've been there 15 years ago, taking the papers and the money and the business cost. So you can use this and you can keep track of your data and show what you have achieved by having a plan. So let's say on the midterm, this is something that you can do. Of course, if you need many patients, go to China. And our colleague and dear friend, Dr. Li Ku, he implemented this evidence-based feeding guideline. So it was the NEAT intervention. And the protocol is too small to read, but it's a really nice trial. And once again, the protocol is important, but the implementation of the protocol is even more important. If it's just laying in a drawer, why spend so many hours developing a protocol? So the implementation is very interesting. And what you can see in this 97, almost 100 ICUs that were randomized to this implementation trial is that earlier EN was there and delayed PN. It delayed PN. So you could see the increase of patients receiving enteral nutrition in those almost 100 ICUs. And I think that many lecturers of this Congress and symposium agree that mortality might not be the wisest endpoint when you design especially a nutrition trial, because nutrition is one part of the story, and we have learned that there are more intelligent endpoints. But look at the cost reduction. PN is much more expensive than EN. So only from a cost perspective, this is already a good outcome. And then you know that it's more physiological. So I really like the trial because it shows you that it can be done. I showed you 3 trials where it can be done in clinical practice to implement better care. so you can feel empowered by those examples and read in the papers how did they actually do it. So change implementation can be done, but of course there are other subjects to address. For example, what about the costs? The costs, you can already go from PN to EN when necessary, because PN saves lives in the case your profiling tells you that this is not a good candidate for enteral. Like we said, don't just watch and wait. You can step in. If you don't use IV drugs, or if the patient cannot take the pills, you will use the IV drugs. You're not gonna say, oh no, but then I'm just gonna wait until the pneumonia goes over by itself, you know, when you have a bacterial proof. So you just use what is appropriate for the patient. But when you are able to use the enteral nutrition, you have to realize that this is something that the gut needs to do. So when you provide the combination of nutrients, of carbohydrates, fatty acids, and proteins, it is worthwhile thinking about the composition of it. Because, for example, the fatty acids that you are providing to the patient, this needs to be, you know, processed by the gut. And if you had some French fries with mayonnaise, you know that sometimes your gut has to work a little bit to digest the fatty acids. Now, medium chain fatty acids, they're smaller. They can be uptaken more easily, and also they go through the portal circulation immediately to the liver. So there is a shortcut. They don't have to go the whole way around. So if you want to maybe reduce the workload, if you want to be gentle to the gut, it would be an option to use these semi-elemental products in some patients. Now, do we have proof? Yes, there is some proof, but sometimes we have to step outside of ICU to see things more clearer. And this is very nice work by Professor Mundi in patients who are exposed to home enteral nutrition, so for a longer time. And what they saw in the States here was that when the complaints were there of nausea, of diarrhea, abdominal pain and cramping, when the symptoms were there, this led to a lot of contact, emergency visits, extra visits, a lot of healthcare costs. And when they made a transition to the peptide-based, they saw that the symptoms reduced enormously. So it reduced also the workload and, you know, of course, the psychological and physical burden for the patients, but there was also an economic payback on using products that were easier to digest. So it was, you know, a relief both for the patients and the healthcare economics. So we have talked about the fact that you can be smart and that you can improve, and please, the first thing you should do is see how are you doing? How well are your patients fed? Do you know it? And if you know it, you can have a plan, you can have a protocol, and you can be smart. You don't want a one-fits-all solution. You can use AI, you can use protocols. Implement a protocol. I've shown you 3 times where it works, so you can do it too. The gut is essential. In some patients, it will just go for granted, but sometimes, please be gentle and find a way around to optimize its use. Patients will benefit, and there will be a lower cost. And with that, I would like to thank my colleagues who also look at post-ICU, because nutrition world is a very good world. We force our forces, we unite our forces very well. And secondly, of course, thank you to my team in Brussels to take care of the food of patients in a daily routine and also to perform excellent research. So thank you for your attention on this presentation.